general idea you need to have is that in the plasma, we've got all of these circulating proteins, which are normally inactive and need activating normally by each other, with or without cofactors like vitamin K, for example, in order to make a clot. So the clot is ultimately the thing that you want to make at the bottom. It involves the conversion of the fibrinogen into fibrin. So all of this is going on in the bloodstream. So you can break down molecules of fibrinogen to make fibrin. And ways of assessing that in the lab, in vitro, so not in a natural way, includes all of the coagulation tests that you know, the PT, the APTT, the thrombin time, the fibrinogen, the G dimers, which will give you a general idea of how this coagulation cascade and the activation of these proteins by each other works to the formation of the clot, and what happens to the clot after it's formed as well. Central to this is the factor 8 and the factor 9, which you can see really in the middle, of the cascade, because that's the activation of the factor 10, the 10A complex, which will lead to the activation of the prothrombin into thrombin, and the thrombin is the one that's going to cleave the fibrinogen. So the three factors that are mainly involved there in the middle are the factor 8, the factor 9, and the factor 10. So when you do a PT, a prothrombin time, you're basically assessing the factors 2, 5, 7, and 10. When you do an APTT, as you can see on the left side of the slide, you're basically trying to assess the presence of the factors 8, 9, 11, and 12. Nowadays, we tend to do fibrinogen levels by the method of Claus, which is the functional fibrinogen. But the thrombin time is a way of indirectly assessing the presence of fibrinogen and how the fibrinogen is working as well. So these two tests, they work together. And the D-dimer reflects the degradation of the clot once it's done. So when you have raised the dimers, it just means that a clot has been made. So this is just to give you a general idea on the number of proteins involved in the activation of each other, and what's crucial is the formation of the fibrin, which is what ultimately going to make the clot. I put here on the corner just a more recent image of eculizumab. I'm sure you would have heard of eculizumab nowadays, because it's entering into clinical practice for patients who have hemophilia A, who lack factor 8, patients with hemophilia A with or without inhibitors. Eculizumab is a monoclonal antibody that bypasses and can act in lieu of the factor 8, because it brings those two factors together, the factor 9 and the factor 10, in the absence of factor 8. So that's a clever molecule that can carry on with the activation of this cascade in the total absence of factor 8. And we've been using this for hemophilia A recently. Next slide. So we're just going to go to the cases, and I'll try to be perhaps more brief now, but I will need your help with that. So this is a 2-year-old child who is 3 days post-cardiac surgery and who has a routine coagulation screen done. He has a PT of 14, an APTT of 74, a thrombin time of 55, a fibrinogen of 2.5, normal D-dimers, So what do you think about these results? On the right side of the results, you have the normal values. So we've got really a prolonged APTT, fairly prolonged APTT, and a prolonged thrombin time, and the rest is pretty much normal. So what is the likely cause of the coagulation defect? I will need someone to say something at some point, so to make this a bit more useful.
Is it hyperemetic coagulation?
Sounds very much like it. So next slide. So we've got the answer, heparin contamination. And how would you confirm this? A little slower. Can you go back, Albert? Just one. Yeah, that's it.
Sorry.
That's okay. You don't know the slides. So how would you confirm this? So you think that this sample is contaminated with heparin because you've got a prolonged APTT and you've got a prolonged thrombin time. It's either contaminated with heparin or this baby is still on the circuit, on the bypass, where you give, you have to anticoagulate them with unfractionated heparin. So how do you prove that there is heparin in the sample that's in the bottle that went to the lab? So you can do the next, because we all know now. So you use an heparin antidote or something that inhibits the heparin, which is protamine sulfate. So you do a protamine sulfate correction, and you can prove that that's heparin. The next slides. So causes of a prolonged thrombin time. So reduced fibrinogen would do that due to whatever cause, either because you're consuming fibrinogen or because you're diluting it with lots of blood transfusions in a massive transfusion trauma scenario, or you've got fibrinogen that doesn't work, that you don't have fibrinogen, or in the case of afibrinogenemia or dysfibrinogenemia, when you have a fibrinogen that doesn't work, or when you have increased fibrin degradation products in case of disseminated DIC, or you have liver disease. And the third cause, and probably the most common that we'll see in clinical practice, is contamination by heparin. So next. So when you see that, you always want to know, is the patient on heparin? If the patient is not on heparin, the lab will do a thrombin time. If the thrombin time is prolonged, they will automatically do a protamine neutralization, and they'll probably just put the report in the system, sample contaminated with heparin. You probably saw that because they would have called you to say this patient needs repeating. Repeating the sample. I think that's probably it for this slide. Next slide. Case 2. So this is a 3-year-old child who presents to A&E with a history of fever and a particular rash, and had the following coagulation screening: a PT of 12, which is normal, an APTT of 55, which is prolonged for a 3-year-old child, a normal fibrinogen of 2.5, D dimers of 0.3, which were normal, platelets of 330. So what is the differential diagnosis? And Albert, do not change the slide.
So it could either be a streptococcal phenomenon, or it could be meningococcal infection potentially, but most likely it's going to be something like lupus anticoagulant.
Yeah, because the streptococcal, the meningococcal, you've got people who are fairly unwell. So you're thinking about DIC, maybe vasculitis, isn't it? And you're thinking about perhaps thrombocytopenia as well. And in this case, the platelets were entirely normal, and the child, it's only a bit of fever and the rash, so not terribly unwell. But yes, those are the initial diagnosis, lupus anticoagulant. But there is something else as well that you may want to include in the differential diagnosis. Because it's an isolated prolongation of the APTT, isn't it? Lupus anticoagulant is a good one because it is the most common cause of prolongation of APTT in a well child like this, who only has a mild petechial rash, which can be caused by any viral infection.
Would it be something like an incidental mild factor deficiency that's only
being absolutely factor deficiency. So any prolongation of the APTT. So next slide. So we see the first answer. What's the differential diagnosis? So either intrinsic factor pathway factor deficiency. Next one, or a lupus anticoagulant. So those are the two most common things for us to see when you see an isolated prolongation of the APTT in someone who's relatively well and you're not thinking of DIC. So what tests would you do next?
So I would either check factor levels, looking for the intrinsic, and as well as von Willebrand factor, and probably do direct antibody tests for lupus anticoagulant.
Yeah, exactly. So next slide, or next for the answer. So a 50-50 mix, a lupus screen, and intrinsic pathway factor assays. Now, 50-50 mix, what is that?
So would that be adding donor plasma to the test, to blood sample you want to test to see if it corrects? That would suggest that it's a factor deficiency.
Exactly.
And if it doesn't correct, it would suggest that it's an inhibitor.
Exactly. So you want, when you mix normal plasma, which is supposed to have all the coagulation factor levels within normal limits because it's from normal donors, when you mix it with whatever sample you've got in front of you that's not normal, if it's a factor deficiency, it will correct because it's getting some factor from a normal donor. And in the lupus is an antibody that interferes with this coagulation cascade, whether you have enough factor or not. So if you add more factor, it doesn't really normally change much. So that's right. So the 50-50 lupus screen and intrinsic pathway. So next. So in this case, the 50-50 shows some correction. So what is the likely diagnosis?
So factor deficiency.
Exactly. And the next slide. Yeah, and if it shows no correction, next slide. That's it. Next. In this particular case, it was a lupus, and the patient only had a little rash with, a viral, probably petechial rash. So lupus anticoagulant is very common. It's non-pathogenic. It prolongs the APTT, and very rarely is associated with antiphospholipid syndrome in children. It is something that you worry more about in adults. But you can have antiphospholipid syndrome in children, but normally you would have someone with some sort of thromboembolic event, plus the evidence, the laboratory evidence of the antiphospholipid present, the lupus anticoagulant or the anticardiolipin or the beta-2 glycoprotein 1 antibodies there present. But normally it's a test that we do just to assist in the differential diagnosis of an isolated prolongation of the APTT in a well child. Next. Case 3, 3-month-old boy brought into A&E, collapsed, had a PT of 20, which is prolonged, an APTT of 103, which is well prolonged, thrombin time of 30, which is prolonged, fibrinogen of 0.8, which is low, D-dimers of 0.8, which in this case is high. So what is the likely cause of the abnormal coagulation screen? So this is an unwell child who has all of the coagulation screening tests off. So this is the one that you think, next slide, you think of the meningococcal sepsis, you think of DIC, which is probably the most likely explanation in this case. Obviously, it's very artificial, me just telling you a child is unwell, brought in, collapsed. It could be all sorts of things, but it's just to give you an idea that in the unwell child and badly abnormal coagulation screening, DIC is obviously a cause that needs to be in the differential diagnosis. So what would you expect the full blood count to show?
Probably raised white cells and thrombocytopenia, perhaps.
Yeah, if it's infectious related, high white cells. Next slide, thrombocytopenia, sometimes red cell fragmentation as well. And how do you treat that? DIC with abnormal coagulation. Next. You have to treat whatever is causing it, obviously, to begin with, and you give blood products if the child is bleeding. So next slide. So this is a term male baby who had a non-eventful vaginal delivery, had some jaundice on day 1, and had a venipuncture to do some bili levels, and had this really large hematoma. That's what it looks like, tense on the hand. So what do? You've got someone with a big bruise, send a coagulation screening. Next. So, and a full blood count, of course. So the full blood count was normal, only had raised bilirubin on the biochem, and the coagulation screening showed the PT of 14 and APTT of 74. So the PT is normal, the APTT is very prolonged, thrombin time is 12, and the fibrinogen is normal as well. So what do you think about the results?
Did they get vitamin K?
What would you have expected with the vitamin K deficiency? The main abnormality in a coagulation screening, if this is a vitamin K problem. But that's a good question. Prolongation of the PT mainly, isn't it, Albert? If you've got because of the factor 7 and all of the other vitamin K dependent coagulation factors, mainly the PT would be prolonged. This is mainly an abnormality of the APTT. So it's a baby that was born and suddenly had a big bruise. So next slide. Next one. Obviously, you need to know that children don't have the same normal range for PT, APTT, and really for all of the other coagulation factors than adults. And there is also a difference between term and preterm babies. But this table is just to give you an idea on how different it can be. So for the term baby, an APTT of 44 in the first few days of life, it's normal. It's not prolonged. The same goes for the PT, which can be can look more prolonged than the adults, just because of how more immature the coagulation system is in children. But obviously in this baby, the APTT was 70 something, so that's definitely prolonged. Next. So we've got a baby with a big bruise on the hand, so you need to exclude any family history of bleeding, and you can carry on with investigations. I mean, we saw that doing a 50-50 could help with trying to differentiate between coagulation factor deficiency or a lupus. I mean, you wouldn't expect really a lupus in a baby like this, but you do the APTT 50-50 mix and it corrects to 42 seconds. So you suspect that this is a factor deficiency, and remember the factors involved in the APTT, the 8, 9, 11, and 12. Here, we're only showing the 8 and the 9, but I can tell you the 11 and 12 are normal as well. And this baby had a normal factor 9, because you will see that 39% for this baby at this age, day 2 or day 3 of life, whatever, is normal, and a disproportionately low or less than 1% of factor 8. So what do you think that this is?
Hemophilia A.
The severe hemophilia A, isn't it? Next slide. So this is just to show how different the factor levels can look on a term baby as compared with an adult. I think this is just in percentage. For example, if you look at the lower row, for example, factor 8 and von Willebrand, 1.5 and 1.6, so just to show that during birth they're all elevated as compared with a standardized one for the adult, and all the other coagulation factors, the 2, the 7, the 9, 10, 11, 12, and 13, they're all reduced. They're below, they're lower than the adults. So, for example, the factor 2 is 50%, the factor 7 is 50%, and the factor 9 is 30%, 35%, and so on. So, and all that, you know, improves with age at different rates for different factors. And it is different if it's a preterm as well, but we're only showing that. But it is important to know that because the factor 8 is expected to be normal or even supernormal at birth, any reduction in the factor 8 will pick up even mild hemophilias A. Yeah, so if you do a factor 8 on a baby, a newborn, and it's low, it is low, there is a problem, okay? Because babies are supposed to be born with adult levels of factor 8 or even higher than that. So this test would probably not only pick up a very mild hemophilia A, but would pick up certainly all the severes and certainly the milds and moderate hemophilias. Not the same hemophilia B, because the factor 9, as you can see in the table, is naturally low at this age. So if you get a borderline based on the day of life and based on whether the baby is term or preterm, if you get a borderline factor 9, you will not really know. You may need to do some follow-up over time, or you may decide, if you have a high clinical suspicion, just to do genetic testing to see if there is hemophilia B, obviously, assuming that there is no family history of such. Next. And next. So the diagnosis in this baby is severe hemophilia A, because the factor 8 is certainly unequivocally low. And how do you manage this bleed? What do you do for this baby at this hand? Say it again.
Give factor acutely.
Yes, next slide. So recombinant factor 8. Next. So you know the inheritance for hemophilia, A and B, they're both X-linked. So if you have a mom who has 2 chromosome X's and one is got a mutation, she is a carrier. Because of the lionization of her X chromosomes, she may or may not have low levels of factor 8 or 9, but she can certainly pass the mutation on. If it's to a daughter, the daughter will be a carrier. If it's to a son, he will be hemizygous for that mutation, because he will only carry that chromosome X, and he will be an affected hemophiliac. Next. The severity depends on what the baseline factor is. So the classification, long-standing classification over the decades has been severe hemophilia A or B less than 1%, moderate when it's 1 to 5, and mild when it's over 5. You know that people who have hemophilia normally can have spontaneous bleed, which is normally in the joints. But the neonates can have lots of problems with big bruises in venipuncture sites, certainly heel stabs, or IM injections. That's why when we have a potentially affected child because of positive family history, we tend to avoid at all costs all these things until we can clarify whether the baby is affected or not, if that hasn't been done antenatally. And now, obviously, we treat hemophilia with prophylaxis, which has significantly improved their quality of life over time. Next. So this is a 4-month-old boy, PICO transfer with a history of lethargy and seizures. On the CT, had a subdural hemorrhage. There was a query NAI, and the coagulation screening. You see how useful the coagulation screening is as an initial test. All of our big problems here, they start with the coagulation screening, and then you follow on the clue. PT of 13, which was normal, a very prolonged APTT of 85, fibrinogen of 4.8, which is normal, and a D-dimer of 1. So what do you think? Let's see what's next. So baby had a 2-day history of lethargy, irritability, reduced oral intake, no history of trauma. The fontanelle was bulging, and there were signs of shock. There was seizure. The CT, you know, so the hemoglobin was low. The APTT was prolonged at 85. It corrected on the 50-50 mix. The factor 8 level was less than 1, which gives a diagnosis of severe hemophilia A. And the patient was treated with recombinant factor 8 and needed neurosurgery. So this is just to show another potentially life-threatening and of a potential long-term disability complication of babies with severe hemophilia A, which is the intracranial bleed. And basically, we all fear that case coming our ways. We have had patients, next slide, who have presented with subdural. As you can see, patient number 2. This list is not really updated, but you can see a lot of bruising as presentation, hematoma at vitamin K injection, bleeding post-anti or previous arthropathy, but you can have the subdural intracranial bleed as well. More recently, patients have got 4 or more probably. They all presented with the ones who were not known with soft tissue bruising when they're born, and it's not expected for the child to have a bleeding disorder following venipunctures. So that's a common thing in the neonatal ward when we see patients like this. Next. So case 6, moving on, 3-year-old severe hemophiliac has a sudden increase in joint bleeds despite being on prophylaxis 3 times a week with recombinant factor. So the APTT is prolonged. It can be better than this. You know, if it's pre-prophylaxis day, it will be prolonged anyway because the factor level will be low, hopefully above 1, but low. So the APTT will be prolonged anyway. The PT is normal at 12, and the rest is fine. So what's the likely diagnosis? Some hemophiliac who has been treated with factor and all of a sudden starts to bleed. Anybody?
So he's developing inhibitor.
Exactly, yes. So that's probably the most likely explanation. Next. So what would you expect the 50 mix to show? Little or no correction. because it is an antibody, and whether you add more factor, it doesn't really matter much. So that's the Bethesda test that we do to prove that there is an inhibitor and to measure its activity level as well. So next. Bleeding post-dental extraction. So this is just a couple of slides to introduce the next theme. I know that we started very late, but I still have 5 more minutes, perhaps. Is that right? Is that 1 hour, this slot?
We'll allow you 10.
All right. Okay. Thank you. So bleeding post-dental extraction, 40-year-old boy, recurrent bleeding post-dental extraction, prior bleeding history of bruising and epistaxis, no other surgical challenges, and there was a maternal history of post-surgical bleeding and postpartum hemorrhage. So what investigations do you advise? So there's no answer to this. If you press next slide, you will take you to the next slide, really. But it's really just what we've been talking about. So probably a coagulation screening to begin with, isn't it? So you can see if there's any obvious abnormality on the coagulation screen. So a PT and APTT, a D-dimer, certainly fibrinogen. Next. Next. So the APTT 50-50 makes correct to 30 seconds, so it was prolonged, the APTT. Next. Factor assays, factor 8 is 35%. Next. Diagnosis, mild hemophilia A, is that right? So it's a 40-year-old with a low factor 8. So a 40-year-old, we saw that even babies should have adult levels of factor 8, which is 50 to 150. This is 35. We saw that the definition of mild hemophilia A is anything when the factor is above 5, right? So is that correct? Next.
It might still be von Willebrands.
Very good. Exactly. Next. Next. Needs to rule out von Willebrand disease. Why is that, Albert? Why can it still be von Willebrand? So why in this case the factor 8 is low when the von Willebrand is low?
Is it that the von Willebrand multimers will carry the factor 8?
Exactly. So the von Willebrand molecule helps with carrying the factor 8 and increases its half-life in the blood. So when you don't have enough von Willebrand, the factor 8 will also reduce. You will still be able to make it because you don't have a problem with the factor 8 production of the gene. So the factor 8 is being made, but it's lasting less time in the bloodstream. So in this case, both the von Willebrand antigen and the activity were 20. Next. So the diagnosis type 1 von Willebrand. Next. So von Willebrand, the von Willebrand molecule is quite a clever molecule. It's really important in the whole of the hemostasis in helping with the formation and the stabilization of the clot. Helps with the other coagulation factors and the platelets because it links the platelets to the site of exposed collagens when there is endothelial damage. And as we just discussed, it carries the factor 8. So as with any other protein deficiency, you can have type 1 defects when there's a problem with how much of it you make, so a quantitative deficiency, or a type 2, a qualitative deficiency, where you make enough of the protein, but it doesn't work properly. And the type 3 is when you have almost complete absence of Willebrands. Next. So the inheritance is usually autosomal dominant, but recessive forms exist. The bleeding is different from the bleeding in patients who have hemophilia because it's usually in the mucosa, and it's rare to see von Willebrand's bleeding in the joint unless it's a type 3 von Willebrand, who will also have very, very low factor 8 levels, as low as in severe hemophiliac levels. The coagulation screen usually shows a prolonged APTT because the 8 is low, but it can also be normal in milder forms. And the treatment for these patients, you can give them DDAVP, which temporarily increases releases von Willebrands molecule for a certain period of time into the bloodstream, and that works for type 1s and for some type 2s. You can give ready-made von Willebrand factor from donors. Tranexamic acid helps a lot, also depending on the clinical scenario and what you want to do with the patient. And now we've got entering the market, finally, the recombinant form of the von Willebrand molecule, which we will start to use soon as well, because it's just been approved and we're now buying it. And you will probably see it in the ward at some point. Next. So just to summarize, the prolonged APTT, physiological, can be physiological, normal for age. Heparin contamination, DIC, problems with intrinsic pathway, a lupus anticoagulant, or liver problems. Next. So an 8-week-old baby is brought in with intracranial hemorrhage and bloods in her stools. Now this baby has a normal APTT. Our previous intracranial bleeding baby had a very prolonged APTT. Remember, it was in the 70s, 80s. This one has a very prolonged PT in the 80s with an okay-ish fibrinogen and the dimer. So what is the likely diagnosis in this case? So it's a prolonged PT, it's a baby, and it's an intracranial bleed, blood in stools as well. Next. Unless you want, that's it. I was going to say, unless you want to give me the diagnosis of vitamin K deficiency, which is the most likely explanation in this case. It's very prolonged PT. And how do you treat that? Next, vitamin K. You can also give ready-made factors, vitamin K dependent coagulation factors, ready-made powders that you just resuspend and give. So it's called PCC, 4 factors PCC that you just get in the blood bank. And how should the diagnosis be confirmed? Next. I can't read it because I can't move this thing here, so I can't read what's written in the slide, but I suspect how the diagnosis can be confirmed. So you do all the factor levels for the vitamin K dependent coagulation factor levels, and they're all reduced, and you see all of the other coagulation factor levels normal. So you make the suspicion. Right, next. So vitamin K is essential for activation as a cofactor of those vitamin K dependent coagulation factors that I mentioned, the 2, 7, 9, and 10. It normally gives you a prolonged PT and APTT and a normal thrombin time and fibrinogen. Some APTT can be normal because the only vitamin K dependent coagulation factor in the intrinsic pathway is the factor 9. And there's 3 other coagulation factors in the thrombin time test that are vitamin K dependent, so that's why it tends to be more affected as well. Vitamin K deficiency bleeding usually can cause hemorrhagic disease of the newborn. This can be early, which is associated with maternal anticonvulsants. Classical, normally presenting from days 2 to 10 of life, or late when there is other underlying conditions associated. Formula mucus supplemented with vitamin K, and intramuscular vitamin K results in supraphysiological levels. So that's probably okay. So that's the vitamin K deficiency that you mentioned about, Albert. And it's very important to look at the coagulation screening to suspect that this is vitamin K related, because it's very easy to treat. Next. So cause of prolonged PT, we discussed vitamin K deficiency. Obviously, if you give warfarin, if you've got liver disease, DIC will prolong the PT and the APTT, as we discussed before. Or if you have specific, normally genetically determined inherited deficiencies of the extrinsic factors, pathway factors, 7, 2, 5, and 10. Okay, next. Not got much time left, but let's see what's next. So this 18-month-old is brought in with intracranial hemorrhage with no history of trauma. What is the differential diagnosis? So I'm sure it's in your head now that you want to see a coagulation screening. You want to see whether the PT is very prolonged and the APTT is normal, or you want to see whether it's the other way around, the APTT is prolonged and the PT is normal. Obviously, you want to make sure that there's no trauma. Next. So bleeding disorder obviously needs to be a differential diagnosis. NAI tumor, next. But the clotting screen and the blood counts are normal. So are there any further hematological investigations needed? This baby has an intracranial bleed, has a clotting screen, entirely normal, normal PT, normal APTT, normal fibrinogen. Anyone?
Did you do platelet function assay?
Say it again.
Platelet function.
You could think that there is a problem with the platelet function. Yes, platelet function tests are difficult to do in neonates, but you should include in your differential diagnosis platelet dysfunction. So we're talking about which platelet dysfunctions that can be severe at birth. So Bernard-Soulier and Glanzmann's thrombasthemia. So that's fine, but there's something else that we have to think about as well that normally presents with intracranial bleed and has an entirely normal coagulation screening. And it's important that you diagnose it because the treatment is also easy, but you need to know it's there because otherwise you don't treat it and the child will carry on. Carry on?
Is it factor 13?
Exactly. Okay, so next. So factor 13, so we talked about, factor 13 platelet problems, like we discussed, and the von Willebrand screening is also important, but it would probably have to be a baby with a very low 8 and a very low von Willebrand to have a spontaneous intracranial bleed, whereas factor 13 deficiency and platelet function disorders can happen, spontaneously. So you're right. Factor 13 deficiency is something that you need to go after because we normally don't do it automatically, the test here when there is bleeding and the coagulation screen is normal. Next. Couple of more minutes then. 24-year-old premature neonate has the following coagulation screenings: APTT of 69, a PT of 14, D-dimer of 1.2. What do you do? APTT of 69.
Is there actually any signs of bleeding?
No signs of bleeding. Next, good question. No, unless they're bleeding. So they're normal, actually, these results for a preterm. I can show you at some point in the ward the tables that we use, the range, the normal ranges, they vary quite a lot. Certainly in the preterm babies, they have fairly abnormal, as we call it, normal ranges. So I think you should probably try to keep the fibrinogen above 1 for anybody really. But that looks fine. If baby's not bleeding, that's within normal limits. Next. So just this case, and then I'll stop. This is a quick one. Generalized rash, What can you see or not see in the blood film?
Platelets.
Exactly. There's no platelets. Next. So blood count showed platelets of 5 with normal hemoglobin in white cells. What else do you do? Next. So obviously in ITP, probably the most important thing is the history and the examination with the blood film. Next. All of the other tests that we do are just to make sure that we don't find the trigger for that. So reticulocytes, to make sure it's not, a microangiopathy as well. Viral serology to try to find out whether there's any viral infection triggering it. Clotting to ensure that the bleeding on the skin that you can see is only to do with the platelets, and it's not DIC as well. The antibody screen, the autoantibody screen, like ANA, for example, and immunoglobulin levels, because common variable immune deficiency can present like that. Next. How do you manage? Next. We know how to manage ITP, so it's supportive. We only treat when there is wet mucosal hemorrhage, because it's been associated with the risk of intracranial hemorrhage, and use IVIG and steroids if you need to use to treat. What would you tell the parents? Next. So certainly not to make it worse. So avoid non-steroidal anti-inflammatories. Give them access to the hospital 24/7, so we can make a decision whether the child needs to be treated or not, and that the vast majority of them will resolve in 6 months. Next. So 6 months later, the child is well, but the blood counts are still low. The platelets, 15. What do you do? Now it's changed to 12 months, but we tend to keep it at 6 months. So next. We do a bone marrow. We tend to do a bone marrow just to make sure, we're not dealing with a differential diagnosis, incipient myelodysplastic syndrome, for example. You reassess the history, you reassess the condition, really. So the differential diagnosis, chronic ITP or any other autoimmune disorder, you go after other things that you haven't thought about or didn't look like to begin with, because it's an ITP that hasn't really gone in 6 months. Nowadays it's 12, it's changed, but you start thinking about investigation. How would you treat? Next. As before. I think I'm going to stop now. I probably only had a couple more slides, but it's just to give you an idea of common things in pediatric hemostasis that we tend to be asked about, and I'm sure you would have if you carried the phone at some point, at least here in Glasgow, and so I would ask if you had any other questions, but I think we're pressed for time now. I'm sorry it started late. I'm still struggling with keeping up with this technology and don't have full control of it yet.
That's your question. Dr. Pinto, I was just going to ask for the new diagnosis ITP regarding avoiding contact sports. Sort of how long would you advise that for, and then how often are you checking the platelet count?
Okay, so the first part of the question is we just say it's sensible to avoid contact sports when the platelets are low, as long as the platelets are low. The families will do whatever they want. I mean, we've got ITP patients who carried on doing taekwondo, and they come to clinic to say, oh, it's non-contact taekwondo, which you don't believe because you see the bruises. It's a balance between what you advise, and it's difficult for us to say, oh, if you go and do taekwondo, you know, you're going to have an intracranial bleed, because no one can tell really. It's always a combination of things, but you have to advise to avoid situations of potential trauma as long as the thrombocytopenia persists. And the second part of the question was, just say it again. I forgot.
Just how often you are checking
Oh, how
the
often?
platelet count.
So you don't really need to do, you know, you only repeat the platelets to find out whether the ITP has remitted. You don't do it just to see that it's too low or how low, because as you know, the number, if it's 2, 3, 10, 20, it doesn't really matter. If the child is well and asymptomatic and not needing treatment and not having wet mucosal bleeding. So we tend to see them, it depends on the age as well. If it's smaller ones, you know, less of a typical age for ITP, or even if it's an older one, teenage one, for example, which is less of a common age for ITP, you tend to see them a bit more often in the beginning, so you can make sure you've got all of the other differential diagnosis tests done to make sure you are dealing really with an ITP and not anything else. So you tend to see them, you know, once a week, and then once every 2 weeks, and then once every 3 weeks, and you just space out, and then you plug them into a clinic appointment and see it once every month or every 2 months. But just remember that doing the blood tests, the blood count, is only to find out when it's likely to be gone, really, rather than to, you know, to tell you whether it's going up or down, you know, the levels, because it doesn't really matter.
Sure. Okay, that's great. Thanks very much, Dr. Pinto. Thanks for speaking and sharing those slides. I thought they were really good cases, and actually very common in general pediatrics. We get lots of phone calls like that. So I think it's been a really good session. It's all been recorded, so it'll be available on the MSN CYPC YouTube channel for any of your colleagues that are on here that are interested in catching up on it later. And the last thing just to say is Victoria's posted the SurveyMonkey in the chat box. If anyone that's not done the SurveyMonkey before on a previous chat, if you could do it again, please. We're going to just make some modifications, hopefully quite soon, based on your feedback. So thanks very much.
I just forgot to mention something. I need to thank Liz for the slides as well.
Sure. Great.
Brilliant. Thanks very much.
Thank you so much. Okay, bye-bye.
Thanks, Dr.
Thanks, bye.
Pinto.
I like who said that when it's safe to say for co-oping, say, and I take the templates.